Very good morning, friends. Today we are going to talk about protracted bacterial bronchitis. It's a very useful topic, both in the clinical practice as well as social point of view. Actually, this has been cited in the literature with various names, not only a protracted bacterial bronchitis, as a persistent bacterial bronchitis, and or a persistent endobronchial infection. All these things, I think better we stick on to this PBB. That's a better one, protracted bacterial bronchitis. Actually, this is a very new disease or new terminology. Actually started from Australia, probably from 2006 onwards. A lot of researchers in Australia worked on chronic cough, particularly the chronic wet cough, and then finally they come to this clinical entity. Actually, what is a PBB, that is protracted bacterial bronchitis, means there are three clinical criteria. Number one, there should be a persistent wet cough. Okay, that is very important. It should be more than 4 weeks. Number two, the child should be healthy without any symptoms, and the child should respond to amoxiclavulinate combination. Amoxiclav. This is very, very important. What they say, some children may respond 2 weeks, some children may go even up to 4 weeks, and if all the three clinical criteria are met with, you can brand them as PBB. The child suffered protracted bacterial bronchitis. First case, this is a 4-year-old boy. He is presenting with a cough, wet cough, according to the mother. Actually, I also saw in the clinic the child is coughing, and the mother is very clearly noted the symptom. And it is already seen by 4 doctors, given various antibiotics, and that is what the usual history, and that is happened in this child also. And with this, what are the differential diagnosis? Actually, this is very important, because I am presenting PBB, that is the reason we can understand, but we should know how to differentiate the other conditions. Cough variant asthma, actually there should be a background of asthma and trigger induced symptoms and dry cough. This is all the things that goes with a cough variant asthma. It is a type of asthma, and there is a typical history, prolonged history, recurrent history, trigger induced symptoms. Coming to the GER, actually some children, probably in younger age group, we have to rule out this, you all know. Even we have to suspect the silent reflex. If the child typically has temporal relation with the food or vomiting, you have to rule out this. Mycoplasma pneumonia, actually last year before, there is a surge. Actually, it's a very common, I think it has been well reported in CDC as well as in Japanese literature. There is a surge of this mycoplasma pneumonia, even in younger age group. And any children presenting with a dry cough, increasing cough, headache, extrapulmonary symptoms like sore throat, it is a combination of bacteria plus virus. And I think one clinical point or clue I can say that if 2 or 3 members are affected in the family, or if the friends are affected, you have to suspect. Upper airway cough syndrome, actually here there is a chronic infection going on the sinuses, and the mucus gets dripped down, and this causes irritation, causing sometime before we can call post-nasal drip. And this child is classically fit into the protracted bacterial bronchitis because of the wet cough, no other symptoms, no fever, normal child. And we have to necessarily rule out pertussis, typical history, nobody can miss it. If you have a doubt, ask the patient to sit in the clinic and listen the cough. Tuberculosis invariably present with though cough is there, predominant symptom will be fever and loss of weight and social contact history. So this child is fitting all the criteria. So the child has been diagnosed as a persistent bacterial bronchitis and has treated with the amoxicillin. In 2 weeks, the child responded well. That's a very interesting. Actually, when this before starting this topic, I brush up my mind. I started all the case when they come with a cough. Most of the times we used to think of asthma. I think you have to keep this in your back of mind also for a better treatment. So again, I reiterate that PBB is nothing but a persistent wet cough for more than 4 weeks. Otherwise, normal child respond to amoxicillin 2 to 4 weeks. So the most important thing is you have to differentiate what is dry cough and wet cough, because most of the mothers may not know the difference, because that too, it all depend upon the literacy. Some educated mothers very easily pick up, and unfortunately the other group, they may not be in a position to differentiate. Best thing is ask him to sit in the OPD practice, and when the child coughs, you go and listen. That is a very easy one, I can say that. And another child, more or less same presentation, cough presenting for more than 1 month, wet cough. Child has given repeated steam inhalation and also some nebulization also. Actually some construction going on, and the child has been already started with some antibiotics, so they came to move. It also fitting to the diagnosis of PBB. I started with the amoxicillin, but after 2 weeks when I saw the child, I usually ask them to come for a review. At that time, the mother says that still cough was present, and she says that she is not happy. Still the child is having a problem. So here I extended the same antibiotic for 2 more weeks. Then the child becomes completely normal. The mother is telling, doctor, now child is completely normal, doctor. I have been suffering for the last 2 months, and now my child is all right, very good. All these things will be there, and you will be. Usually they used to see 3 or 4 doctors before seeing you. The literature says many number of doctor visits, and I am saying my experience. Okay, this is, I saw that, and this already we discussed. That is the way you have to. So the response to amoxicillin either maybe 2 weeks or 4 weeks. That is very important. I always stick on to 2 weeks. Then when the child is improved, okay. Otherwise, I will extend and all. I think a lot of studies were done. Which are the organisms causing this persistent or protracted bacterial bronchitis with the BAL, bronchoscopy and BAL, and they found 3 organisms, particularly the Haemophilus influenza, non-typable. Actually, because of the vaccine, the typable has come down, but non-typable is circulating. And another one is Streptococcus pneumonia. We don't know. It may be zero replacement. And Moraxella. Actually, these 3 organisms are very commonly seen in the community. They colonize the upper airway, typically affects in the younger children, and they also has a tendency. Sometime before we thought even the Pseudomonas is the only organism for biofilm. Now these organisms also tend to form a biofilm. So you have to be very careful, and that is the reason why even though it is a clinical diagnosis, you should have a knowledge to pick up the. Otherwise, once neglected, some children will be even they not treated for even 6 months and all. Then what will happen? That is what we are coming to the. There is some connection between PBB and bronchiectasis. Actually, is there any connection? Yes, definitely. What the literature says, 8% of them, if they are not treated with the proper time, neglected, then they may go. Now, I am not telling all the children. This study shows like that. But what I want to say that if a child had a recurrent PBB, more than 3 episodes, definitely these are the candidates. They may go for a bronchiectasis. Why I am cautioned this is, actually this is a spectrum. That is a protracted bacterial bronchitis, chronic suppurative lung disease, bronchiectasis. Once there is a structural damage occur, then it is called as a bronchiectasis. All the 3 conditions have a chronic wet cough, and the study shows that somehow the endobronchial infection is persistent in the child with presence of neutrophilia, and that causes the damage. That's the reason why we should be very very careful. You have to have a early diagnosis and all. And if you not treated this condition in a time, they may progress to the CLD or even a bronchiectasis. Actually, if you look at the bronchiectasis picture in the world, in some areas it's very very high. Some areas it may be very low. That's what 50 to 1000 per lakh. And one more thing is 30 to 50% of the bronchiectasis we don't know the cause. We know it is a TB may cause, or CF cystic fibrosis, or some necrotizing pneumonia. Now the addition is I want to say that if this correct treatment is not given, they may also go for a bronchiectasis. I think that is the reason why I think even in your busy practice, when the child gives a prolonged history, you ask the patient to wait for some time and you send away the cases and look for, we should not be only tuned to look for asthma that's being a cause. And this is also one of the condition. Some of the, even I say, some of the children with asthma do develop. That's a very important way I want to say that. That's the reason why ERS statements say that these topics needs further research. We have to watch for the mechanism. It's observational research, and the young doctors who can take this as a study, and you can observe the natural history of PBB. In my observation, I think the combination of air pollution and bacteria, it is a bad combination. They form a vicious cycle. Nowadays, it has been reported that air pollution is increasing in major cities. Unfortunately, if a child lives in a roadside and if get infected, it's vulnerable. See, the most important thing is the particulate matter size also, that I have been talked that particularly the particles of 2.5 micron, nitrous dioxide and all, have a potency to cause, even enter the circulation, not only cause the damage and all. And this knowledge is very important. And so to sum up, protracted bacterial bronchitis is a clinical diagnosis. Like asthma in younger age group, it's a clinical diagnosis. So any child presenting with a chronic cough, particularly a wet cough, we have to be very careful. Then no investigation is generally not required, and you have to treat with the 2 weeks of amoxicillin. Not response, go for 4 weeks, and still there is no response, you have to investigate. Or if the child started recurring these symptoms, you have to document in your diary or prescription. Then you have to go for investigations like HRCT and bronchoscopy to rule out structural damage. I think this is the last slide. Thank you.